premature birth affects an estimated 13 million babies worldwide annually. NICU infection, intraventricular hemorrhage, periventricular leukomalacia, chronic lung disease, necrotizing enterocolitis, and retinitis prematurity are all recognized long-term sequelae of premature birth. Surveillance for these early morbidities with quality improvement initiatives to prevent their occurrence is a focus of nearly every NICU. Because cerebral palsy, visual impairment, hearing loss, shunted hydrocephalus, and cognitive impairment are early sequelae of these morbidities, and seen as early as 12 to 18 months postnatal age. Growth failure and chronic medical sequelae, for example, feeding problems from gastrointestinal failure and chronic respiratory problems, may result in frequent hospitalizations as well. Learning disabilities, behavioral problems are detected at a later age, probably due to brain connectivity problems. White matter injury resulting from ischemia or systemic infections or meningitis affect the trajectory of brain development. These and other inflammatory conditions such as chorioamnionitis, which is an inflammation of the membranes, or necrotizing enterocolitis, an inflammation in the bowel, result in destructive processes leading to deletion of neurons, axons, and glial cells, which lead to micro and indeed macro cysts in the brain. Milder insults, however, involve disruption of the maturation of the glial progenitors and neurons, causing a more diffuse white matter brain injury. And while some cells resist cell death, they do fail to generate a normal arbor of dendritic processes and spines. In other words, brain injury seems to involve primary cerebral dysmaturation, which may be indeed amenable to strategies promoting brain maturation and hence improve neurological outcome in our premature babies. While the maximum development of brain occurs between 29 and 41 weeks gestational age, a time when these babies are frequently in the NICU, noise, bright lights, ill-timed caregiving activities, indeed, are all known to adversely affect this brain development. Some medications may even affect brain development, causing injuries such as steroids or aminoglycosides, such as gentamicin, a form of antibiotic therapy, or indeed diuretic therapy. In addition, multiple painful and stressful stimuli are also linked to maturation in gray and white matter and impair brain function. Parental stress and anxiety also are very important determinants of outcome, especially when they interfere with parental bonding. Developmental care aims to reduce the stress and promote neurological development in these preterm babies. This requires modification to the NICU environment and indeed care practices. Attention to noise, light, and position of the newborn can reduce stress to the infant. This occurs through optimal handling and positioning measures, a reduction in those noxious stimuli in the environment, such as light and noise, and more cue-based care, providing care for the baby when the baby is ready to receive it. This also requires a lot of education and attention to the family needs in the same environment. Here pictured are examples of an NICU with developmental care being practiced. Whether the baby is in the overbed warmer on the left-hand side of the slide or in the covered isolette on the right-hand side, a great deal of attention is paid to those noxious stimuli and making sure the babies are in a safe and environment which reduces their stress. You can see in the same unit a dearth of personnel. In fact, on the right hand of the slide, you'll see that the nursing staff caring for these babies are paying most attention to the monitors, which provide them with the physiological data so that they can monitor their babies carefully without consistently interrupting the baby's sleep. Another example of the same NICU, clearly with the isolette covered to reduce the amount of noxious stimuli. And here's an example of noise meters that are used to ensure that there are visual cues to the staff when the noise level reaches a certain high level of decibel. Implementation of developmental care requires ongoing assessment of the infant, positioning, and parent involvement to involve them in the interventions which empower them to recognize behavioral cues in the newborn. Cue-based and clustering of cares requires timeout and modification of cares to suit the baby's or the infant's tolerance. Clustering cares to minimize handling protects deep sleep. A great deal of attention is paid to stressful or painful procedures to minimize or provide appropriate pain relief measures. And this would include non-nutritive sucking, containment of the baby's arms and legs through swaddling, grasping the finger of the mom, preferably one of the parents, and giving babies sucrose at the time of painful procedures. Staffing requires modification too in an effort to provide continuity of care, handling the infant to maintain the infant in a semi-swaddle position, and reducing the amount of contact as much as possible. I've already mentioned noxious stimuli, and in fact this leads us on to the idea of Kangaroo Care, which really does improve state organization and reduces oxygen needs, including a reduction in apneas and bradycardias, improving thermal regulation, enhances parent-infant bonding, and the parental sense of competence, enhancing cognitive and motor development. Here's an example of a mom enjoying swaddling her baby in a typical skin-to-skin or Kangaroo Care position.